I'm going to tell you a story, really, in terms of where we are in Croydon in terms of our journey with transformation. And the key elements for us is about pace of getting things done and moving on. And the objectives that were set for me was about how have we responded to our inheritance as a CCG, given that we're in month 3. Something about what we've already done and what we're doing now in the process of in terms of moving forward. I'll touch on some areas of transformation, but also some concepts relating to how do we create the pace and the impetus for change without getting bogged down in organisational integration, and also aligning some incentives and levers in the system to make it work. So those are roughly the objectives that I have in mind in terms of covering the agenda today. So I'm only going to talk for about 20 minutes, and we'll have about 10 minutes for questions. So just in terms of context, our local health economy has pockets of deprivation, has life expectancy hasn't really changed very much since 1995, and our big killers are cancers, circulatory disease, respiratory disease, childhood obesity. We've made progress with teenage pregnancies and repeat abortions, but we have a huge problem still relating to uptake of immunisations. And given our high ethnic population, we have increased TB, and we also have a high level of STIs, as well as neonatal issues. So probably not that much different to lots of different parts of the areas. We have pockets of severe deprivation and pockets of relative affluence. We have 61 practices spread around Croydon, and 91 care homes with nursing and 27 without, which again poses a challenge in terms of managing a population that is diverse at both ends of the spectrum. From a finance point of view, as a CCG, the vast majority of our budget, like everywhere else, is spent in hospital. The primary care budget is not significantly high, and out of hospital care is one of those things which is an aspiration, and we need to think about how we can move this going forward at pace. So really, I'm going to pick up the presentation in terms of moving on, in terms of some of our service challenges. We have a perception that it's difficult to see a GP, and maybe in reality true, in some parts of the borough. Patient experience at our local hospital has been not very good in some areas. We have a high emergency admission rate, readmission rate, and A&E attendances. And the 95% for the 4-hour target has been challenging, to say the least. Again, some of these issues are not necessarily unique to us, and lots of other areas will have similar ones, especially the last one. And again, to put it into context of where we're going, because it's not only about, as a CCG, we need to have a strategic overview of where we are now, but also where the population is going in terms of planning ahead. We have a high ethnic population of nearly 60%, and we have extremes of age relating to both the young and older people in the borough. And it's set to rise in specific areas, especially the young and the very old. So that presents significant challenge going forward. So, given that the population has gone up, does that mean that the system has been kind to us and given us this extra resources? Absolutely not. And we're well below our target in terms of our population growth. So to add to our already difficult circumstances, we've got another whammy that's been thrown at us. So, I think when you've seen one, you've seen them all, and hopefully that's the last whammy in the foreseeable future, in terms of we're going to have even less resource to play with. So, even before we knew about the allocations, we already had our own challenges. So we inherited a deficit, which was discovered in 11-12, and an understating of the budgets, an accounting error, we were told. And in reality, it's something that is recurring, so we've got to carry that forward. And our financial challenge this year is 42 million, and our quip for this year is about 14 million. But what's different is we can't go to our members and say we're in real dire financial straits and then we're going to have a balanced budget. It doesn't make sense. And we said that to them the last year, and they said, well, you're in deficit, so how can you have a balanced budget? So we have to face reality and be transparent, is that unless we want to slash and burn, we can't have a balanced budget, so we're filing for a deficit budget for this year of 19 million, nearly 20 million, which is a big change in the approach of NHS organisations. But it's saying as it is, and certainly in terms of our local politicians and our local media, is welcomed, rather than fudging the issues and saying that we can do this, that and the other and we're in balance when we're not. So we've already got a history of delivery. So the quip in terms of 11-12, 12-13, over 38 million already delivered. So we have a track record of getting on and doing things. And as the time goes on, it's going to be more difficult. We've not cut any services, so there's been no slash and burn, and there's not going to be any slash and burn this year either. It's about the components of quip in terms of improving quality, using innovation to drive the change, using productivity to be maximised, and actually everyone forgets about the last P, and it's about prevention. So if we want to make a difference, we need to be acting on all four components of quip. And we have a quip programme this year, which is starting with prevention, self-management, shared decision-making, and into other areas which everybody should be looking at, relating to shifting care, integrated care, prescribing, working jointly with the local authority, developing a joint commissioning unit, and looking at contract management levers. Now, Paul didn't mention how long I've been a GP. It's 24 years. And I must say, the management team that we have now is the best management team I can ever remember having to work with or seeing above, but actually working with together. It's a smaller team than the PCT used to have, but it's a productive team. And as you can see from what we've already delivered, they're all on the same wavelength. And we've got some of the commissioners here who are, one of the aspiring leaders in the PCT to make this happen. So this is not about jobs worths or process. This is about getting on and doing, because we're in a difficult position. So where we started with, it's a topical subject. Do we understand our local health economy? Whatever you read in the press, the facts are the facts. These are our facts. It may be different in your area, but I think it doesn't require much intelligence to know that there's a direct correlation there between deprivation and A&E attendance. What about GP access? Well, there's not so much of a correlation there in totally. You've got some areas where perceived access is poor, but people don't go to A&E, and there's some areas, some practices, where perceived access is really good, but they still go to A&E. So there are other factors, but the only correlation that is strongest is deprivation. A&E demand is predictable. It has always been predictable. It's the most predictable demand in the system. Yet we hear it taken out of context, nationally, locally, everywhere you can think of. We know where the peaks are going to be. We know how it's going to rise on an hour-to-hour basis, and there's patterns to show that. We know that there is a peak after morning surgeries, when GPs go out and see their patients and then refer them to hospital. So having intelligence about your own local health economy is absolutely key to understanding how you can change it. And we know about target-driven behaviour. If you're in A&E, the closer you are to 240 minutes, the more likely you are to be admitted. It's an exponential curve that confirms that. And this is not going to be different to any other health economy in the country. So what we did, starting back as Pathfinders in 2011, is trying to engage practices in terms of having more of a handle on urgent care, increasing capacity, even if it was by 1 or 2 appointments per clinician on a Monday. Having a preventive approach in terms of developing the notion of having rescue packs for all COPD patients. And we've got 4 practices now piloting Doctor First, in terms of radically changing the model of general practice, because the current model of general practice needs to evolve and evolve rapidly. Having a pan-Croydon or pan-CCG, PCT as it was then, urgent care network, was an absolute necessity to make sure that we move forward as a health economy. And looking at pharmacy first, so that patients don't need to go to GP, A&E or any other part of the system, but can be helped to self-care. We changed the out-of-hours contract to an urgent care contract. We launched 111 in March 2012, implemented an urgent care centre in the following month, in April, based on the commissioning guidance of the RCGP. We work with the ambulance service in terms of developing alternative care pathways, and being part of the clinical quality review group for the ambulance service, for example, not conveying people, as an example, people who've had hypos. They don't need to go to hospital if they've been recovered. So being able to have developed different pathways, not to take people to A&E unnecessarily, maybe to take them to an urgent care centre or not take them at all. And it's only quite recent that just by introducing rapid access and triage and treatment, the A&E has begun to improve. But really the hub of all this is changing the mindset of not only clinicians but also patients, in terms of talk before you walk or phone before you go, which will probably be the statement of choice, in terms of getting into the mindset of citizens that actually, rather than going to A&E or any other part of the NHS, they can certainly phone for advice. So the model that we worked on was relating to the model that was outlined in the commissioning guidance that's in the RCGP guide. And what we've achieved in this is about a 40 to 50% reduction in attendances. 40 to 60% of adults are now seen, treated and discharged, and nearly 70% of children are seen, treated and discharged from the urgent care centre. So a streaming model integrated with out-of-hours, integrated with 111, and working with the emergency department. It's not been plain sailing in terms of transformational change, and sometimes you need disruptive innovation to bring about change quickly. Culture takes a lot longer to be embedded, and I think it's no mean feat, and my commendations to the managers that have tried to manage the change, because managing clinicians has been difficult enough, but managing other managers is probably more difficult. So what's been the outcome? There's no point having change. What has been the impact? Wherever you are in the country, there has been very little change in A&E attendance. It's no different in Croydon. Regardless of what you read in the papers or you hear in the news, the A&E attendance, ED attendance is flatlined. So those are the facts, no matter who spins it in whatever way you want to see it. So introducing the UCC on the graph on the left obviously shows a reduction in EED attendance. The other element was, is it out of hours because of the 111 element that has gone up? And you can see from the graph on the right, there's no impact of out of hours at all. And in fact, in the news about the 2004 contract, there's no connection whatsoever. But in our little health economy, there is no element relating to out of hours that's influencing the changes. The next thing is about the impact of 111. Again, you just have to pick up any newspaper, read it in every magazine about what's happening. But this is what happened is happening in our health economy, a reduction in the activity to GP out of hours. There's still a perception of impact on 999 ambulance services at A&E, but we know A&E attendance hasn't gone up. We know that some of that activity has gone into in-hours general practice. Haven't been able to quantify that. So if they're not going to the A&E, then they couldn't have gone to the ambulance service in the first place, because otherwise the ambulances mainly take them to A&E. So the impact has been significant, and there are unforeseen issues relating to impact, because we anticipated some change, but not to this degree. So 50% reduction in out-of-hours activity is quite a huge reduction. And the A&E target has still been difficult to achieve, which then points to what is the causes of A&E, the target issue. If you're optimizing A&E, then the issue has to be the flow through A&E and through the hospital, and requires good operational management and understanding of what the issues are. And I think it can't be underestimated that a lot of blame gets apportioned to different parts of the system. And, I'd question whether A&E is the barometer to the NHS, because certainly more urgent care takes place in general practice than it does in A&E. In launching 111, we also launched a palliative care register, and called Coordinate My Care, and this is London-wide. And that's linked to 111, and it comes up as a flag. And some of the early data shows that if you look at the graph on the right-hand side, on the bottom, number of people that are dying in hospital is reduced compared to London and England. So transformation has to be more than just urgent care. It has to be much more a whole system approach. And early on, we decided on 2 cohorts, the frail elderly and children and families. And part of the transformation is to shift care from acute settings into less acute settings, into primary care closer to home. And having prevention, self-management, shared decision-making, driving this with a primary care strategy. So this is where we're at the moment in terms of the transformational priorities. There is an implementation plan, and it's on schedule to move things along in all those 7 domains. But the final P of QUIP has to be the key to unlock transformation. And there's a whole load of work streams relating to transformation. A single point of access, for example, for community services. Developing risk stratification, and we rolled out risk stratification, I'll come back to that, across all the practices within 3 or 4 months. And developing the end-of-life care in terms of coordinating it. And then ensuring that we've got the right levers in place to look at the whole system, not only health, but also social care. It's a big cultural change for the system, and we're already looking at redesigning diabetes, cardiology, respiratory care, dementia and cancer in the next year, or within the next year. We're already looking at how we can use technologies, telehealth, to support this transformation, and how practices can start working in hub and spoke way, in networks. So really just to be less reactive and more proactive. So with the children and families agenda is developing family engagement partnerships, which are live, and looking at how this links into prevention, how we fit in with the Troubled Families initiatives, try and reduce domestic abuse, and really think about health and social care outcomes, not just in terms of social care in this case. Working together, local authority, children's services, health professionals and the voluntary sector has been the hub of trying to move this along, and actually has moved it a long way. And the Health and Wellbeing Board is key to helping facilitate this. Family engagement partnerships and children's centres are across the borough, and they're aligned with the GP networks, and they're aligned with community services as well, so that we begin to wrap around community services around general practice. I showed you the map of Croydon before in terms of where the practices were, and this is the map of where the children's centres are, which are coterminous with commissioning networks. So to be able to be proactive, you need to be able to identify at-risk patients. You need to be anticipatory rather than reactive and have early intervention. So we've looked at all the different models of integrated care around the country, and there's more spin than action, more spin than outcome. We haven't got time for spin strategy. We want outcome, because we're on this platform that we're on. So we need to think and do as we go along, but at the same time have a vision and a strategy of what we're doing. So the commissioning networks, as I said, are now set up from April. They've got a finance budgets, a finance manager to a clinical lead leading it. And it's so important to develop clinical leads in terms of succession planning going forward. And then the age-old question, so who do you concentrate on? And up to now, people say, well, you concentrate on the top of the pyramid. But if you look at a regression to the mean, we've never been successful at that, because those are the people that always will behave differently because you put some action into them. So if we want to make some real change, then we need to look at the next cohort down. And the evidence base for that is actually quite huge now. So it's identifying who we want to look at, developing some of these multidisciplinary teams, and this is where we're at in terms of trying to move that agenda forward in the next month or two, now that the GP networks have started. And developing a case management approach. And the sad thing about, you've got this momentum is information governance holding you back. Being able to share information between health organisations, but also between health and social care organisations, and we need to get that cracked. But from the panel session I was in earlier, it happens that it's the law that is the barrier to this. So we need to find ways of getting around information sharing across the country. You've heard of lots of organisational change. We've had enough organisational change, I think, in the last couple of years. We can't afford to have more and have more time wasted. We need to have functional integration at the level of the patient. And we've got structural integrations in terms of our acute trust and community services, but it's about how we integrate them in a functional way. And we're looking at the community contract, and we're looking at scoping even yesterday, what is it they're going to be doing, and we'll be finalising signing those contracts within a week or so. And looking at things in a different way, having a single point of access, a rapid response team with a 2-hour response. We've spent months and years sometimes looking at common assessment frameworks. So why don't we think about a single trusted assessment where health and social care can agree on? And looking at how community services, social care can wrap around those GP networks and family engagement partnerships for children. Developing a joint commissioning unit is at this moment in time progressing, and we're already working jointly with the local authority in terms of learning difficulties, mental health, children, reablement and end of life. So that virtual integration between health and social care is absolutely integral. While we're challenged in terms of finances, so is the local authority. They're more challenged than we are. So we're in the same boat relating to finance, and we need to find a common purpose and a common will in terms of removing waste from the system, but duplication is one of the biggest issues to overcome if you're commissioning jointly. Now, if that wasn't everything, then we've got a major plan of transformation across southwest London. We've got 5 hospitals. We can't sustain the acute services and the hospital services in the way they are. It's been clinically led, and the emerging themes are related to maternity and newborn, restructuring where emergency services would be, children's services, and also out of hospital and planned care, as well as end of life. So this is a major reconfiguration proposal involving 7 CCGs. And the PCBC has just been agreed by the 7 CCGs, and that will be going out for consultation in the coming months. So to align incentives and levers to drive some of this, and this is what we've used so far, thinking differently, because we're on a burning platform. We need to invest to save, to do things much more quickly. Focus on quality, look at service redesign, re-procurement where necessary. Not to slash and burn. Use sequence much more holistically. Community services, alcohol services, use LESs and DESs more creatively in terms of part of the bigger strategy, in terms of not only GP engagement, but also delivering outcomes. So it's a major program of Invest to Save that we're embarking on now. So in summary, we find ourselves on a burning platform. QIP is not the only answer. Well, QIP is not the answer. We need to transform. We need to use QIP to be able to enable us to transform. We've had to respond to this challenge of an inherited deficit. We've redesigned a lot of the urgent and emergency care system, and we're now transforming the rest of health and social care working together. And we need to modernise and change the way we work, not focusing on the structural integration, but focusing on the functional integration, and ensuring that we align levers and incentives across the whole system to be able to do this. And working together with the CCG, the providers, local authority, the voluntary sector, Health and Wellbeing Board, it can't be done just by any one organisation. It has to be everybody. And as always, the proof of the pudding is actually getting on and doing it. And I think the one thing I've learned in my time in general practice is that we've always had more strategies than we can paper walls with. And we've always talked and talked and talked. And I can honestly say in the last year, 2 years, I've seen more change than I have in 23 years, 24 years as a GP. So I think having the right team is absolutely key in terms of management. Having clinical leadership has made the change. Having clinical engagement at the grassroots level is absolutely key to moving forward. I'll stop there. Thank you.
Thank you very much indeed. That was very interesting and gives a lot of food for thought. Now we're running a little bit behind, so I think we can probably just take probably one question. So let's have a start question from this lady here.
Thank you. My name's Lynn Morris. I'm a nurse practitioner in Chessington. Does having the urgent care centre based at the front end of A&E reinforce the message to patients that minor ailments should be treated in A&E and secondary care?
Those patients, is that on? Those patients that would go to A&E would still go there. However, if we want to change the mindset, we need to start with the professionals. So part of the role of the urgent care centre must be to empower them where to go the next time. And we've not always done that before. So I think we need to move from the system we're in now to where we want to be. We have to start somewhere. And that prevention, self-care, self-management agenda is absolutely key. And if we're going to think about phone before you walk as a concept to implant in people's minds, self-care first, pharmacy first, even before touching any part of other parts of the system. So it's a big cultural shift, and we can't do it just in health. We need to use the Health and Wellbeing Board, we've got to use the local authority, we've got to use the voluntary sector, we need to use our PPGs and our practices, we need to get the mindset of clinicians thinking differently.
Thank you. Right, we're just on time now, so I'll close the session there because we've got quite a complex session next. But thank you very much again. I'm sure you'd be happy to answer some questions outside if necessary. Thank you very much indeed. Thank you.